Hello people. So today's class will be on Bullous pemphigoid. So for such lesions we will receive a skin biopsy specimen which is very tiny, that the growth is not that much remarkable, and we are directly awarded with the slide. So in the slide we see a section from the skin showing a vesiculobullous lesion below the epidermis, which consists of hemorrhage, and the dermis shows perivascular lymphocytic infiltrates and patchy dermal lymphocytic infiltrates with areas of hemorrhage. So we straight away from this microscopy won't write it as a bullous pemphigoid because the findings are not that specific. So we will request or order for immunofluorescence and clinical correlation, and later it's a multidisciplinary diagnosis of bullous pemphigoid. And discussing the pathogenesis of this disease, we have to understand what's normally there in the basement membrane. So what is shown here are the basal keratinocytes. If this epidermis have this basal layer of keratinocytes, which has a lot of intermediate filaments here and there between them, and what we need to know is the ones below, like attached on the bottom surface of this basal keratinocytes are hemidesmosomes. So hemidesmosomes are pretty important in this bullous pemphigoid, and the cell is attached to the hemidesmosomes by means of two cytokeratins, which is cytokeratin 5 and cytokeratin 14. So underside of the hemidesmosomes we can find three other molecules, two molecules of integrins and one molecule of type 17 collagen. So this type 17 collagen and hemidesmosomes play a major role in binding this keratinocyte to the bottom dwelling collagens. Okay, so the underlying three molecules of these integrins and type 17 collagens are bound directly to the type 4 collagen by means of what is known as anchoring filaments, these linear ones. So these anchoring filaments are composed of laminin and nidogen 1, which is not needed in this pathogenesis, but just for the time being. And the type 4 collagen is again connected to the type 1 and 2 collagen by hooking, literally hooking type 7 collagen. So that's it. And the type 1 and 2 collagen are normal collagens in the dermis, so that's why it's being discussed here. Actually the basement membrane is just this much. Now it is classified, this bullous pemphigoid is classified under the epidermal basement membrane region vesiculobullous lesions, which shows a linear pattern of immunofluorescence in the epidermal basement membrane zone for C3 and IgG. Now coming to the etiology and epidemiology. Okay, so the etiology, it can occur as an autoimmune process where antibodies generated against the bullous pemphigoid antigens, PP antigens, BP antigen 1 and BP antigen 2. BP antigen 1 is BPAG 230. BP antigen 2 is BPAG 180. The one is intracellular component of the hemidesmosome, which we have already seen, and the other one is the transmembrane protein known as collagen type 17, which we have seen here. This is the type 17 collagen and this is the hemidesmosome. And it can be drug induced, like in case of furosemide. And epidemiology, it usually occurs the older category. Now the clinical features, it presents with a large dense bullae on articulated erythematous area or non-erythematous area. Erythematous area and non-erythematous area is stressed here because of a different type of classification which we will discuss in the microscopy. and it can be Nikolsky sign negative because it's a subepidermal lesion. Now, sites include trunk, extremities, intertrigus area between the fingers, and oral mucosa. So this is how the bullae and plague appears in the clinical photograph. So coming to what is what in skin lesion. We have highlighted the size of 5 millimeter here because if the lesion is flat, it is either a macule or a patch. If the lesion is raised, it's a papule or plague. If the lesion has fluid in it, it is a vesicle or bullae. If the fluid has a neutrophils in it, it is called a pustule. So, if the lesion is less than 5 millimeter, it is a macule, papule, vesicle, and pustule. If the lesion is more than 5 millimeter, it is a patch, plaque, or bullae. And it can also be a pustule. So I think that's clear. All that is written on the top is less than 5 millimeter lesions, and all that is written on the bottom are more than 5 millimeter lesions. So coming to histopathology. Early lesions might not have any sort of bullae formation, so it can be there can be something what's known as a pre-bullous phase, where there will be papillary edema. The dermis will have papillary edema. We can see white spaces, and the dermal inflammatory infiltrate can be perivascular and intermediate. There will be lymphocytes and eosinophils. It is again classified based on cell-rich and cell-poor variants. Cell-rich variants, we have discussed something in the clinical features, that bullae in the erythematous skin or non-erythematous skin. So cell-rich variants are the blisters occurring in the erythematous skin. There will be there will be eosinophilic papillary abscess and a blister formation with eosinophils and other lymphocytic infiltrates inside the blister, and there will be perivascular eosinophils, and there will be interstitial inflammatory infiltrates. Now the cell poor variant, on the other hand, is actually blister in a relatively normal skin. We can see the blister here. We can see this blister space between the basal keratinocytes and the upper dermis, and there will be scant inflammatory infiltrates. Even though the photo shows a lot of inflammatory infiltrates, it's actually not that. So old blisters can migrate to the top and mimic an intraepidermal blister. And also it can lead to pseudocarcinomatous hyperplasia of the epidermis, as in pemphigus vegetans. So the ancillary studies which I have already told is, one is direct immunofluorescence. So the pattern will be as discussed. It will be linear against IgG and C3. And 25% of the lesions will show IgA and IgM linear patterns. So we confirm this with what is known as salt split. We will treat the tissue with salt water. So not salt water. We will treat the tissue with a solution which we will describe later. And so the blister is cracked between the basal keratinocytes and the dermis, and the immunofluorescence pattern will be retained in the roof or roof plus floor, because hemidesmosomes are present in the basal keratinocytes, and collagen 17 is attached to basal keratinocyte. So it can be roof or artifactually roof plus floor. So salt split, we use 1 mole per liter concentration of sodium chloride. So the salt split occurs in the most disrupted layer of the basement membrane. This is the basement membrane picture we have seen earlier. So lamina lucida is the layer of anchoring filaments. Here the salt cuts through these anchoring filaments. Hence, hemidesmosome and type 17 collagen appears to be in the roof of the blister. So these two are the differential diagnosis. One is EBA, epidermolysis bullosa acquisition. So EBA, there will be a floor-only immunofluorescence pattern, and the antibodies will be against type 7 collagen. The type 7 collagen is actually well below the same. Like types, I haven't included in this picture. This red thing is the type 7 collagen. So the other differential diagnosis is the cicatricial pemphigoid, which is actually very close DD of bullous pemphigoid. The antibody will be against BPAG2 and sometimes against collagen 7 and sometimes against lamin. So all the antibodies, all the cicatricial pemphigoid lesions with antibody against BPAG2 is almost as equal to bullous pemphigoid. So this is the table showing the salt split pattern of the lesions here. You may take a screenshot. And these are the clinical nomenclature of what is described in the previous table. That's all, folks. Thank you.